Hello there, my name is David Dr. David Liu, and today we are going to be talking about asthma in kids by using the RCH guidelines, and we're going to talk also about the Australian Asthma Handbook's chapter on asthma in children. So, asthma is a really important disease to know because it's super duper common. You see it in the ED all the time. You also see it in general practice. In fact, basically anywhere, anytime you have to deal with kids and even adults, you will deal with asthma. But today we're just going to be talking about the kids aspect of things. First of all, when kids come in, first of all, asthma is a chronic inflammatory disease of the airways. I hate this picture. I really, really hate this picture. It's from Canada, but that's not why I hate it. It's just because it's really disgusting. Anyway, basically, you see that the here is just a normal airway, not constricted at all, not inflamed at all. And then when you have an asthmatic airway, what happens is that things do get inflamed and then thickened, and then during an attack, it gets so narrow that it actually causes you to have shortness of breath. And because it goes narrow, it's kind of like a whistle, so that's why it makes a whistling type sound. And you do even get tight and smooth muscles as well. You can get some air trapping with that too, and you look a little bit like this gentleman spitting out yellow things, air particles. Children that are less than 12 months of age presenting with wheeze, don't necessarily consider them as asthma. It's a little bit too early, and first of all, ICH says that. Second of all, the Asthma Handbook also says that. They shouldn't be treated for asthma per se, because basically they won't have asthma. They'll probably have acute viral bronchiolitis, or sometimes they have small floppy airways. So if you're thinking of giving like salbutamol or corticosteroids or inhaled corticosteroids to an infant under 12 months, you should really be talking to a pediatric respiratory physician rather than doing that in the ED, or rather than doing that even as a general pediatric physician. If they have clinically significant wheeze that necessitates the hospitalization or occurs frequently between the age of 0 to 12 months, then they should also be referred to a pediatric respiratory physician. But let's not go too far into that. Let's talk a little bit more about asthma history and examination in general first. So the history of asthma involves how long have they had the symptoms, what's the duration for, have they tried any treatments, for example, like salbutamol relievers or other types of preventing medications that are inhaled? Were there any particular trigger factors? So, for example, upper respiratory tract infection and is a very, very common cause due to the actual infection itself causing a bit of inflammation of the lungs, but not necessarily pneumonia, just a bit of bronchoconstriction that's reactive. Sometimes just being in the presence of other people smoking can unfortunately cause that as a trigger. If they get a sudden onset of symptoms after like an insect sting or some food or medication, then you have to think, is this wheeze really asthma, or is it actually anaphylaxis that's affecting this child? Think otherwise, if you're still going with the course of asthma, just ask about the pattern and the course of the previous episodes. Have they ever needed to be hospitalized before? How often do they get it? Have they needed IV treatment or ICU admission? All of these particular things affect the disposition of the patient in terms of, one, do they need to stay in hospital, and do they need to be admitted to hospital in the first place? But also, two, what is the extent of the follow-up going to be? Because you have different management for different sort of severity of the different flare-ups. You want to assess how good the parental understanding of the treatment of the acute episodes is. Obviously, if they have pretty poor going with regards to inhaler technique and with regards to the asthma action plan and that sort of thing, then they may be at risk of having worse asthma. And also you want to ask about the presence of interval symptoms. So in between their asthma attacks, what are their actual symptoms like? The risk factors for severe disease, if they've been in the ICU before, if they've had poor compliance to asthma treatment, if they have lots of symptoms in between the actual asthma attacks itself, so basically they're puttering along very poorly, or if they have a past history of anaphylaxis, so in other words, they've got a big IgE component and reactive component to their asthma. On examination, the most important parameters are going to be your general appearance / mental state. So, does this child look well or look sick? Mental state, if they're confused, they are probably sick. With regards to the work of breathing, this is also going to be things like accessory muscle usage, or intercostal or subcostal recession as the other sign of respiratory distress. So if you want to summarize this, think of your PALS, PALS, and then think of your ABC: air appearance, breathing, and circulation. With regards to the saturation and air, heart rate, and ability to talk, they're useful features, certainly, but a bit less reliable. Tachycardia can also be a sign of severity, but the fact is that if you give salbutamol to these children, they might be tachycardic anyway. Things like wheeze intensity, which actually a lot of people think is useful for determining asthma, but it's actually not. It's not that reliable. You might actually get a silent chest with no wheeze, and although you may think, oh, well, I can't really hear the chest, but maybe I just can't hear it. Actually, they may be about to have imminent respiratory collapse. Looking for pulses, paradoxes, and peak expiratory flow rate, so not very reliable in the acute setting. And asymmetry on auscultation. You have to think about a foreign body if you can only hear air entry on one side of the chest rather than the other, but otherwise it's probably due to mucus plugging. So, how do you manage these kids with asthma? So you want to divide the severity into mild, moderate, or severe, as per ICH, or critical. So there's actually four. Let me make that smaller. So there's actually four individual sections, right? And sometimes people get confused thinking that there's only 3 sections of mild, moderate, severe, but it's actually mild, moderate, severe, and critical. The mild children, they are children that just have a normal mental state. They only have a bit of subtle increased work of breathing, if anything, and they're able to talk normally. These kids just need salbutamol by MDI spacer. You want to give 1 dose and review after 20 minutes. We'll talk about doses in a little bit. And then after that dose, you just ensure that the inhaler device is good and the technique is appropriate. If they have a good response to that, then they can go home just on a short-acting beta-2 agonist like salbutamol as needed. You provide written advice on what to do if the symptoms worsen, and I would also consider doing like an asthma action plan for them. Basically, what that means. If they're still not getting better despite that little bit of salbutamol, then you need to go into the moderate stage and then start to treat them a bit more. You can think about giving oral prednisolone to try to reduce their risk too. Before we move on from mild, let's just quickly talk about the doses. So the doses are actually pretty easy. You just need to know that they're based on age. If you're below 6, you get 6 puffs of your metered dose inhaler. If you're above 6, you get double that. You get 12 puffs. So again, below 6, 6 puffs. Above 6, 12 puffs. Easy, right? That's a single. So 6 puffs is a single dose here for the below 6 years old, and then 12 puffs is a single dose for the those above 6 years old. Similarly, ipratropium works on a similar principle, except instead of being 6 puffs, it's actually 4 puffs for those below 6 years old, and then instead of 12 puffs of salbutamol, it's actually 8 puffs of ipratropium for those who are above 6 years old. So let's move on from the mild treatment of asthma and talk about the moderate treatment of asthma. So the difference between the mild and moderate, you can see that the work of breathing is a bit increased. The tachycardia is actually a sign of severity there, and there should be some limitation of their ability to talk. So instead of talking in full sentences, they started talking in much shorter sentences. Now, you give oxygen if the oxygen saturation is below 90%, but don't give it just because they're working hard to breathe or just for wheeze itself. Because it won't necessarily be useful in those particular cases. If they're really, really having a lot of increased work of breathing, you may need to think about and this is like when you're going really far down the track, but it's quite severe. Think about like ventilation, non-invasively, and that sort of thing, because they may need a little bit of help with their airway pressures and stuff. But anyway, the whole point is oxygen saturation. If that's below 90%, just give oxygen. Otherwise, don't. These kids will still need salbutamol. Now, this thing here, one dose every 20 minutes for 1 hour. This is what they call burst therapy. So burst therapy is where you get, let's say that you've got a 5-year-old child, okay? So you know that one dose for that 5-year-old child is going to be 6 puffs of metered-dose inhaler. So with the metered-dose inhaler, you give 6 puffs every 20 minutes for 1 hour. So that's 3 times, basically. You give it once now, once in 20 minutes time, once in 40 minutes time, and then you will review them after that 3rd dose, about 20 minutes after, right? And then you use that to decide on the timing of the next dose. So that's the burst part of burst therapy. The stretch part of stretch therapy is when you're actually trying to increase the time between salbutamol doses to be longer and longer. So, for example, if you're thinking they're pretty bad with their asthma, maybe you want to give them another dose in, say, 30 minutes. And then they're doing okay still, so you give them another dose in another 45 minutes after that, and then another 1 hour, or then another 2 hours, and sort of stretch it out until you get to roughly about 4 hours. Once they get to the 4-hour mark, they're pretty good. And usually, like, the 4-hour mark is probably where you would say, okay, this patient can go home soon. But yeah, that first dose every 20 minutes for 1 hour, that's those 3 doses every 20 minutes, that's burst therapy. Again, consider oral prednisolone. So the dose of oral prednisolone we actually didn't talk about before, but it is 2 milligrams per kilogram with a max of 60 milligrams initially. You then only continue with 1 milligram per kilogram daily for the further 1 to 2 days if there's an ongoing need for further salbutamol. So again, that's 2 milligrams per kilogram to start off with, and then continue with 1 milligram per kilogram for further 1 to 2 days. So we've talked about mild, we've talked about moderate, and so the moderate one is where you might need some oxygen, and then the salbutamol burst therapy is the difference between that and the mild one, where you don't actually have to give burst, you're literally just trying a single dose in that particular case. With the severe asthmatic child, now this is getting quite serious, and you need to involve senior staff when managing these kids. They're starting to get agitated and distressed. They look like they've got accessory muscle usage and even subcostal or intercostal recession. So they're working hard to breathe. They've got tachycardia. They have a marked limitation of the ability to talk. They may have wheeze, but the wheeze part isn't a defining part. It's just something you'll find, but it's a poor predictor of severity. So here, we again give oxygen if they're hypoxic. We again give salbutamol by the metered-dose inhaler or the spacer with burst therapy. And then you want to, again, do the same thing where you review 10 to 20 minutes after the 3rd dose. If it's improving, you can reduce the frequency, but if there's no change at all, you still want to continue essentially at the same rate as the burst rate. So you'll continue it every 20 minutes for a new dose of salbutamol. So if this child is deteriorating even further, then they need to go to the next stage. But let's talk about that after. So we're still going to continue on the severe stage. So we've given the salbutamol burst plus minus more burst. We've given oxygen. We are going to give ipratropium next. This is a short-acting muscarinic antagonist. Does the same thing as opening up the airways, except it acts on a slightly different system. Sorry about my Facebook there. And then this is kind of like the burst therapy, except that if you go, you don't go for more than 1 hour basically. So it's 1 dose every 20 minutes for 1 hour only. And when I say 1 dose, what I mean is the 4 puffs if they're below 6 years old, and then the 8 puffs if they're above 6 years old. So, for example, if you have a 7-year-old child and they have severe asthma, and they're using like their accessory muscles and have subcostal recession, then you'll not only give the salbutamol burst therapy, but you're going to give this 7-year-old child um, 8 puffs of ipratropium now, give it 8 puffs in 20 minutes, give another 8 puffs in 40 minutes, and then that's it. That'll be enough. So with the oral prednisolone, that is something that you'll give these severe asthmatic children as well. And whereas before it was considered oral prednisolone, so I'll just turn that off. Where before it was considered oral prednisolone for the mild or moderate kids, oral prednisolone you should definitely give for these severe asthmatic children to try to reduce their inflammation. So again, that's 2 milligrams per kilogram for the first day, and then 1 milligram per kilogram for another 1 or 2 days after that. If they're vomiting, you can actually give IV methylprednisolone instead of the oral, and again, that's actually 1 milligram per kilogram, but instead of being daily, that's actually 6 hourly. If, despite salbutamol, despite ipratropium, despite prednisolone, and despite oxygen, they're still not responding, then you really need to pull in all the traps. You're going to give aminophylline, I think that's how you pronounce it, or aminophylline. No, I don't know. Here, this loading dose is 10 milligrams per kilogram, given IV. It's a maximum dose of 500 milligrams, and that's given over 60 minutes. Unless they're markedly improved following that loading dose, you can give a continuous infusion or 6-hourly dosing, depending on whether you're in the ICU or on the ward. In addition to the aminophylline, you will give magnesium sulfate 50%. This is again another IV solution. So here you're going to give 0.2 millimoles per kilogram over 20 minutes to a maximum of 8 millimoles. And then if they're going to ICU, you will continue on infusion for them at a rate of 0.12 millimoles per kilogram per hour. Consider adrenaline, and that adrenaline is 10 micrograms per kilogram, or alternatively, if you want to think about it in volumes, it's 0.01 mils per kilogram of 1 to 1,000 adrenaline. And that's quite hard to remember, so I'll repeat it again. It's 0.01 mils per kilogram of 1 to 1,000 adrenaline. And so that's up to a maximum of 0.5 mils. In other words, it's if your child is 50 kilograms, they will get the maximum. But if which is 50 times 0.01 equals 0.5. But if your child is over 50 kilograms, like for example, if they're like 60, I guess, which is pretty heavy, but if they're 60 kilograms, then they will not necessarily need any more adrenaline than 0.5 mils. This adrenaline is actually given intramuscularly, and it's given into the lateral thigh, and it should be repeated after 5 minutes if the child is not improving. And then the children that are severe and have these severe respiratory distress, these ones will definitely need to be admitted after the initial assessment. There's no way that you can just send these children home if they're severe. Finally, talking about the fourth section, which people forget, again, it's mild, moderate, severe, and then critical. So the difference between critical and severe is that you have maximal work of breathing and maximal accessory muscle use in recession. This child is exhausted. They may actually have a silent chest because their airways are so closed that they just have such poor air entry, you cannot hear a thing. These children are also unable to talk. They have marked tachycardia, and they are confused / drowsy. They definitely need to be you need to have pretty high level care in terms of these children. The idea is that now you've just sort of given up on the idea of spaces and gone straight to nebulized salbutamol. So here you're using 2 times 5 milligrams nebules undiluted. You monitor for hypokalemia and toxicity as well for that. So the actual monitoring below is for potassium levels, basically, because they may get a hypokalemia from this sort of thing. The Ipratropium is also going to be nebulized. So you give this at 250 micrograms, added to salbutamol, and this is every 20 minutes for 3 doses only. So again, similar to a burst therapy, except with nebulized ipratropium. Again, the nebulized salbutamol was actually continuous, so you're just going straight for on and on and on and on salbutamol as you can. Rather than necessarily giving a burst therapy per se, as in severe to mild asthma. Methylprednisolone, that's going to be given IV instead of the usual oral prednisolone, because obviously if they're unable to talk and able to really breathe, they're probably not going to have a great time trying to swallow stuff either. So give them the methylprednisolone, that's 1 milligram per kilogram up to a maximum of 60 milligrams, and that's given IV Q6 hourly. You give the aminophylline as well, as we talked about, so 10 milligram per kilogram IV loading dose over 60 minutes. Max of that is 500 milligrams. And then you will give the magnesium sulfate as well in the same doses as we described before. Again, it's 0.2 millimoles per kilogram over 20 minutes to a maximum of 8 millimoles. The aminophylline, the magnesium, and the salbutamol must be given via IV, separate IV lines. You can't mix them together either. The IV salbutamol is another option that I haven't talked about. There's a limited evidence for benefit of that versus the nebulized salbutamol, which is continuous. And if you're going to do it, it's 5 micrograms per kilogram per minute for 1 hour as a load, followed by 1 to 2 micrograms per kilogram per minute. That's quite specialized. Definitely ask your senior staff about that one. If there's other signs of anaphylaxis, of course, then you would consider adrenaline. You would just consider adrenaline regardless, because it's going to be critical asthma. So these, again, is 0.01 mils per kilogram of 1 to 1,000 adrenaline to the lateral thigh intramuscularly. And then repeat that in 5 minutes if the child is not improving. So you kind of think of it along the lines of, I guess, anaphylactic-y type help. This child is not just for ward admission. This child is for intensive care admission, because they will need they may need respiratory support. In other words, they may need continuous positive airway pressure. They may need BiPAP, or they may need even intubation and intermittent positive pressure ventilation. Okay, so that was a lot. So management is mild, moderate, severe, or critical. To sort of summarize, mild is you just give the salbutamol once and give it a shot. Moderate is that you're going to give the salbutamol burst therapy, oral pred, and maybe oxygen. Severe is that you're going to give salbutamol, ipratropium, and oral pred, and possibly aminophylline and magnesium and adrenaline. And then critical is where you're going to have to give nebulized everything. So nebulized salbutamol continuously, nebulized ipratropium, burst therapy. They can't talk, so you're going to give IV methylpred Q6 hourly at 1 milligram per kilogram. And then this child will need aminophylline, magnesium. They'll need maybe adrenaline, and they'll likely need ICU, to sort of summarize all of that. I am just going to very, very, very briefly talk a little bit about the differences between the ages of children and how that makes a difference to how you approach asthma. So this is directly from the Australian Asthma Handbook, and again, I'm once again skirting the boundaries of copyright law by screenshotting this and just reading off this, but okay, whatever, let's do it anyway. Okay, so for children, again, aged 0 to 12 months, as we mentioned before, these kids probably don't have asthma. If they're below 12 months, they probably have bronchiolitis, so you should not be really treating them with beta agonists and that sort of thing, unless, pediatric respiratory physicians say otherwise. Even if you're aged 1 to 5 years, most of these kids with wheeze, infants and preschoolers, they most likely have viral respiratory infections. Even if they don't have asthma, they may still wheeze with viral respiratory infections due to that bronchoconstriction. However, because you're sort of leaning more into the asthma territory, you can still give as needed salbutamol, and there is some wheezing that has been shown to be salbutamol responsive. Some of these, and this is a small percentage, but some of these infants and preschoolers actually need regular preventer treatment for the preschool wheeze. So, for example, if they have recurrent symptoms between viral respiratory infections and those interval symptoms just aren't under control, then you can consider giving stuff like low dose ICS. If they're over 6, then you can make the diagnosis of asthma with more certainty. In this age group, they may have reversible expiratory airflow limitation on the spirometry, and then that would support the diagnosis of asthma. All school-age children with asthma need a reliever to use when they have asthma symptoms, and if they get frequent intermittent asthma, which is where they have flare-ups every 6 weeks or more often, or if they have persistent asthma symptoms, which is basically daytime asthma symptoms more than once per week, or nighttime symptoms more than twice per month. So again, daytime basically 2 days or more, and then nighttime more than twice per month. And those with severe flare-ups. So anyway, for those persistent asthma symptoms kids or the frequent intermittent asthma flare-up kids, they will need regular preventer treatment. So to sort of summarize this entire section, below 12 is bronchiolitis. Don't worry. From 1 to 5, probably a viral respiratory tract infection. Some are responsive to salbutamol, so you can give it a shot. And then some very small subset may need preventers. And then for over 6, then you're like, okay, like this is where I'm more confident of the diagnosis of asthma, maybe on spirometry, because they can actually do spirometry when they're over 6 years old. And then they may need regular preventive treatment if they have flare-ups every 6 weeks or more, or they have daytime asthma quite often, or nighttime symptoms quite often, or they have severe flare-ups. So, yeah. Alright, this video is getting much too long now. I would love to talk about all the other stuff, but I think let's just save that for another video, because I am sleepy. It is 10:49 p.m. and I would like to have a nap before I go to ED tomorrow. So thank you for listening or watching, and I will see you in the next video, I suppose.